Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Building a Health Workforce Center, Lessons Learned in the Carolinas. It was presented by Linda Lacey on June 25th, 2014.
Now, I would like to go ahead and take a few moments to introduce today's presenter. Linda Lacey is the Director of the Office for Healthcare Workforce Analysis and Planning within the South Carolina AHEC Program Office. And she has been involved in the startup of two health workforce research centers, one in North Carolina focusing on the nursing workforce and one in South Carolina focusing on a broad range of health professions. And so at this point in time, I'm going to go ahead and turn it over to our presenter. After the presentation, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure they have an opportunity to be answered. Also, when the event ends, you will be directed to a short evaluation survey. So please, take a few moments to provide us with your feedback. Linda, are you ready to go?
I think so. Can you hear me?
Yes, I can.
All right. Thank you, David, for that introduction, and good afternoon or morning, depending on where you happen to be, to all of our attendees. First, I want to give you a little bit about my background. For 15 years, I was the Director of Research at the North Carolina Center for Nursing, which was a state-funded center focused exclusively on the nursing workforce. For the last 5 years, as David said, I have been the Director of the Office for Healthcare Workforce Analysis and Planning in South Carolina. We were established in 2008 with grant funding from a philanthropy group that focuses on the Carolinas. And our office is housed within the South Carolina AHEC program office. And we're currently making the transition from grant funding to more mixed funding systems. Both of these entities that I've been involved with had very well-established collection systems in place, but the realities of how data and the whole process of developing research worked in those two places was very different. Part of that was that my role was different in those two places. In North Carolina, I was essentially the lead researcher, and I was responsible for developing the research agenda. I had a small but very engaged staff, 2 people actually, but we had a large advisory group, although it was rather homogenous. It was mostly made up of nursing folks and people who were directly involved in nursing workforce issues, and not a lot else. And in this second job, as the director of a startup, it's really more of an administrative role, but it also requires me to be the lead researcher. I have a much smaller staff. Right now I only have 1 person who works with me, and we have a small but a very diverse advisory group. So that's kind of where I'm coming from. And when I was asked to do this webinar, I was asked to sort of talk about, what have I learned over all those years? And it was a great opportunity for some introspection. Usually I'm too busy, really, to think about the big pictures like that. But as I thought about it, what I realized was the biggest lesson that I have learned is that I need to ask more questions. And that's essentially going to be the focus of what we're going to talk about today. Oops, sorry, I forgot about that. So I have a series of questions here, and we're going to address each of these as we go through the webinar. I think that very often when an organization like a workforce center gets started, it's because there's some crisis where people need information. And very often there's not the opportunity to sit back and really think about what is the mission of that organization and taking the time to define it. Because by doing that, by defining your mission, you're really defining the scope of work, and that will have implications for what kind of staffing needs you'll have. It will also have effects on how you structure your relationships with stakeholders. Depending on what your mission is, you may want to have a very broad group of stakeholders involved in an advisory group, or you may decide to follow a different path to get what you need. I think mission also tends to guide your data resource strategies as you move forward in time. So depending on what the mission is, and it's going to be different for every health workforce center, you might want to spend, especially your early years, doing some short-term data projects that give you immediate answers to very hot topics in your state, or if there are no, if it's consistent with your mission, you might want to take a longer-term view and think about spending your first few years building a broad range of data resources. It's really all dictated by what your organization is really all about and what it's focused on, and that's where actually sitting down and defining a mission statement can really be helpful. And finally, we're also going to talk about whether or not you want to get into the business of forecasting demand, because I think that's a legitimate and really important question for new workforce centers. So, what's involved in defining your organizational mission? Well, it's pretty straightforward, I think. But it's shaped by different things. If your mission is dictated through legislation that maybe has set up the center, then things are pretty clear, but that's often not the case. Any organization needs to think about the kind of authority that you have, or if you have any authority at all. I know in North Carolina, we actually were started by legislation, and our mission was pretty much defined within that authoring legislation. But it didn't actually give us any authority. Legislation told us that we were supposed to, focus on nursing workforce issues and, be able to address areas of shortage and that sort of thing, but it didn't actually confer authority. We were independent of every other agency of state government, and therefore we didn't really fit anywhere. What we found was that we gained authority by really developing our expertise and by having good data that was valid and reliable and that people had faith in. And I think that is actually a really important part of developing your authority as a workforce center. If you do have some sort of legislative authority, you need to think about how that intersects with other organizations, because that's also going to play into how you develop your partnerships with your stakeholders. I think as you move through the problem of defining your mission, it's worthwhile to think about who should be involved in that process. Certainly it should be more than just the people who are directly affiliated with the workforce center, and it should probably be a fairly broad range of people that you expect to be working with over the next 5 years. Of course, if it's too diverse a group, then you run into the problem of, different stakeholders have different objectives, and that can become problematic. So thinking about who should be involved in that activity of defining mission, I think, is an important question to ask yourself. And then along with your organizational mission, you might find that advocacy for one or more health professions is sort of blended in with that. When I was in North Carolina, advocacy was a part of our mission. As the Center for Nursing, not only were we responsible for doing research on workforce dynamics, but we also were funded to do workforce development programs. And that was always a balancing act, to try and balance the objectivity of research with the need to think about the advocacy element of what we did. So we tried to define very clear boundaries within our center as far as staff were concerned. There was no overlap. But I think it's also important to think about what the consequences might be if you have advocacy as part of your mission, because it's often the case that if you do have an advocacy role to represent one or more professional groups, then it's hard to be seen as neutral in your research. And so it can be a little tricky. But again, these are questions that I think new workforce centers should ask of themselves, and I think in the long run might help prevent some problems that arise naturally as you go through this kind of work. Maybe the most basic question is, what do you want to build? Is the need great for data collection? Do you need to be a data collection center? Or are you hoping to be a data clearinghouse where you just pull in data from lots of different sources and put it all together and then either analyze it yourself or make it available to others? Are you going to be a research center? Will that be your primary objective, is to do research? Or are you leaning more towards being a policy center? Or do you want to be all of those things? This really seems like a simple question to answer, but the truth is that it probably will morph over time because as you do things and interact with the people in your state and learn more about what the policy questions are and what the resources are, things can shift and change. But I think each of these types of centers has a unique set of challenges and consequences. It's hard to do both research and policy within the same doors unless you really have things that are, being a policy center often means that you're advocating for one course of action over another, and that can color how people respond to your research. So, all good questions to ask as you head off on this grand adventure. Staffing is something that I think nobody ever talked to me about staffing problems when I started on this work, but honestly, staffing can be quite a challenge, and it has been for me for a couple of different reasons. First of all, finding experienced health workforce researchers is very difficult. They're in very short supply. And so chances are you're growing your own. And in fact, you may be one of those people that comes from a different line of research or experience, and you're learning about health workforce issues. I think that that's kind of the most common approach to staffing. If you can find someone that has the skill sets that you need, that's the most important thing. So once you've defined yourselves in terms of your mission and the type of center, that really will help you understand the skill sets that you need. And then you need to give some thought as to where you might find those people. What sort of academic centers are available in your state that might be turning out graduates that have those skill sets? Are there other agencies of state government, if you are connected with state government, where you might find those skill sets? But also I think it pays to think about developing some partnerships with people in academic centers, departments of sociology, economics, geography, certainly health services research if you have that sort of a program in one of your universities. I think those kind of partnerships can really be helpful, and that might mean bringing some of those people into your advisory group, or maybe developing some contracts with them, using them as consultants, or actually using some of those folks to get some of your work done. And then, of course, there's always the idea of students and interns. If you are lucky enough to have a setting where you have space where you can bring in an intern or some grad students, that's a great way to develop some future staff. And it is an ongoing issue, so it's something that I think it pays to think about from the very beginning. One of the things that makes staffing issues complicated, of course, for most workforce centers is that you tend to cobble together your funding from different sources. Most of us do. Very few workforce centers are strictly funded from one source. And that makes long-range staffing decisions sometimes difficult. If your budgets are uncertain, you sort of live from one budget year to the next often. But again, that's where students and interns can be really helpful. They tend to be temporary. Also where contracts and academic partnerships are helpful because they can sort of, grow or shrink as budgets allow. So let's take a minute to talk about partnerships and stakeholders. I mean, as you're doing your environmental scan to see what sort of data resources are out there in your state, you'll also have the opportunity to ask other organizations and other entities about the types of information they need to address the policy issues that they're struggling with. And this is an excellent opportunity to identify your potential partners for the future. So, I think you all know this. You really have to look around and see who is it in the state that either has a need for information on the health workforce or who has an interest in it. And it could be an academic interest or there's all sorts of things. There's a little list on the right-hand side here about the different types of stakeholders that are most common. And you can put these people together in lots of different ways. You may develop an advisory board that meets, on a regular basis, hopefully at least a couple of times a year, to give you feedback and to help you identify policy issues that are happening in the state that will need information, sort of hot topic things. Also, you can use the stakeholders in very project-specific advisory committees, and I think there's a real difference in how you build a general advisory board versus project-specific advisory groups. I think on a general advisory council, you want a wide diversity of people who will bring lots of different opinions and background to bear on the kinds of questions that need to be asked, and will help you think about workforce issues in slightly different ways. When you're doing project-specific advisory groups, though, I think you really want to keep them small, and you really want to maximize the amount of expertise on those. So if you're doing a study of dentists, dental care in the state, you certainly want your advisory committee to have mostly dentists or dental hygienists or organizations that provide dental services, that sort of thing, and not too much diversity. And hopefully you can find people who not only understand their field, but also have a feeling for research and what research involves. Of course, with your partners and stakeholders, it's nice to have one-on-one relationships, but honestly, there aren't enough hours in the day to develop one-on-one relationships with everyone that you would like to. So I think group meetings are another opportunity, even if it's just outside of your advisory board, maybe once a year to pull people together, maybe with a topic to get them focused. But in North Carolina, we used to try to do this once a year and would host basically a 4 or 5 hour meeting. And of course, we would feed people because that's how you get them there. And just have sort of wide-ranging discussions about, what's happening in the world at large that will impact, at the time we were focused on the nursing workforce, and how are things changing. And it was amazing the kind of information that cropped up out of those big meetings. Even though they're large, if you have them in the right kind of room, round tables so that people are actually discussing, it can be extremely productive. And I think those kinds of large meeting group meetings and your advisory council is really important for helping you set your research agenda for the coming year. Your partners essentially are going to define the policy issues that are happening in your state, and they're going to define the data needs. So this is, partners and stakeholders are an essential part of your organization. Building a data system. This little photo that is on the slide here is something that a colleague of mine left on my desk one day. I had provided her with some very simple information about the distribution of, I think it was around pharmacy students, where they were in the state. And for some reason, this just hits jackpot, not only with her, but with the group that she had been working with. And she left this little Data Are Wonderful picture on my desk. I keep it actually pinned to my bulletin board to remind me, you know, data is really how you make friends and influence people in this business. Data is really central to what we do. But there are all sorts of strategies around data and all sorts of problems also that arise. So I'm just going to share with you some of the things that I've learned over the years around data. As I mentioned earlier, you know, you can, a couple of ways to go at things, especially when you're just getting started and in the first few years. A short-term approach is, you know, sort of jumping on things as people bring you problems or as you're aware of pending legislation that would benefit by having some background data. Those are great. But if you do too many of those short-term, very specific, you know, question-oriented studies, after a while they don't hang together in any cohesive way. So things to think about, no matter what kind of studies you're doing, are, you know, if you're collecting data, think about how you might be able to link that data to other sources. So let's say we did a study of nurse practitioners, and we were interested in informing legislation that was going to change their scope of practice. Something was about to sunset. They had been given the rights to direct reimbursement from the Medicaid program, and there was some question as to whether or not that should continue. So we needed to go out and do a survey to find out how many of those nurse practitioners were serving Medicaid patients and where they were located and so on and so forth. This was in, I think, the very first year when I was in North Carolina. And it was a great study, and it was very useful, and it resulted in the legislation being made permanent, so it was useful to the legislature. But afterwards, I realized that there was no way for me to link that data that I had collected back to another information source about nurse practitioners that came out of our license renewal process. And that was unfortunate, because I would have been able to do a whole lot more with that data if I had been able to link it. So it pays to think about those things as you jump into new projects. I think it's also important to think about whether you're collecting new data or if you have data from another source, making sure that you can use it for regional analyses, because statewide information is great, but it's limited in its usefulness. What most folks really want is information about what's happening in their region of the state. And so I think it's important to make sure that you build in some geographic fields into any data that you collect that will allow you to do some refined geographical analyses. And most of you will work with some sort of organization that already collects data. It might be your regulatory boards, and they're collecting information as they do license renewal. It might be your hospital association that is collecting data on their members. There's lots of different organizations. Your Medicaid program may have information. Whoever licenses healthcare facilities in your state may be collecting data that would be useful. And so ultimately you're going to run into issues. I know in South Carolina all of our regulatory boards collect quite detailed information as part of the license renewal process. But our regulatory boards fall under this umbrella board that sort of administers the whole process of data collection. And as a result, the boards have less power and authority over their ability to collect data in specific ways or to change their questions every year. Also, you know, the database managers that are part of this umbrella board, they make decisions about data formats and quality without really understanding how that data is being used by others. And also, the whole process of trying to adopt a minimum data standard or definitions or just even specific questions, if you have something like an umbrella board, it requires buy-in from multiple agencies that have different missions. You have to work not only with the umbrella board, but also with your regulatory boards and with your professional groups. It can get quite complicated, actually. The question of who owns the data is usually pretty straightforward. Usually it belongs to whatever agency is collecting it, but you know, if it's the state that collects it, well, you know, does anybody own it? Is it public information? Is some of it private? And states differ widely on this issue in terms of what data can be shared that is collected by the state. So, and I think there are some real issues here, concerns about data security, but there are strategies. There are ways to get around these things like, you know, developing unique identifiers that are not license numbers but can be linked back to license numbers so that researchers can use the data without, you know, identifying people. Sometimes you'll find that multiple agencies are using the same data source, and often the numbers won't match. So is there an official group in the state that has primary responsibility for official numbers? That's something to think about and talk to people about. But there's lots of ways to share data and build bridges. I think just having conversations on a regular basis with the people who create the data, whoever that may be, and however many people touch it, just having regular communication helps a lot. But technology can be used to mask raw data. You can use data cubes to aggregate data. And mostly, I think, creating comfort zones around data with use agreements or maybe developing public use type files, that sort of thing. And finally, I would say, especially for a new workforce center, that it's important to make good use of secondary data resources. There are a lot of good data sources out there, and this is just a list of a few of the ones that I use all the time. Recently, within the last year, we had a group convene here to look at graduate medical education in our state and how it was or was not meeting the needs of the state. And this was a group that was actually convened by our Medicaid program because our Medicaid program puts a lot of dollars into GME training for physicians, and they wondered whether or not they were getting their money's worth. And as they came together, they came to us looking for some data. We had some stuff on our website that they found easily, and once they knew that we had information on physicians and where they practice and the education pipeline and that sort of thing, we were able to hook into that task force group and supply them with a lot of information for the context of their discussions. And that proved to be remarkably fruitful. And actually, we used pretty much all of these. We certainly used the AAMC's information. Their workforce data books are great. We made big use of the Accreditation Council for GME, looking at the programs in the state and the slots. We even used some of the IPEDS data, which allows you to look at who's graduating and how that's changing over time. We've also used the BLS data in their occupational forecasts for a supply and demand assessment that we did for the RN workforce. And, you know, as you all know, nursing is the largest health workforce profession. You really need good information about nurses, and sometimes it's hard to get. So the National Council of State Boards of Nursing publishes a book every year that summarizes pass rates for the RN and the LPN exams, and it's a good source of some basic information. Secondary data, honestly, has been a big lesson learned for me. I have found that oftentimes it will give me exactly what I need without a whole lot of effort, and maybe more importantly is that it's easily available. You can absorb that data and translate it into a way that speaks directly to the kinds of policy questions that are being asked in your state. I think the important thing is to become familiar with these secondary data sources and become a regular consumer of those sources. And you'll find, I think, that they really become a great backup tool to any information that you might be collecting yourselves. Now, the question of forecasting demand. As a workforce center, is this one of the things you want to do? You know, for most workforce centers, it's really focusing on supply and education that gives you the biggest bang for your buck. The problem is that everybody wants to know, well, what's demand going to be 10 years from now? And that requires some sort of forecasting. You'll notice there's a little caution tape here because I think it's getting into the demand forecasting business is a double-edged sword. You know, it definitely expands your ability to look at potential shortage forecasting and that sort of thing, but it's devilishly tricky to do. It's doing demand studies is a unique skill set. So first of all, it's finding people who can do it or learning how to do it yourself. It's difficult types of research. It's not simple stuff. You can do some very simple forecast assessments or demand assessments, you know, provider to population ratios, and then look at how your population is expected to change. You can use things that other people create, like the Bureau of Labor Statistics and their occupational forecasts. Those are actually available at the state level through your labor market information offices. Or you can get into doing it on your own and, you know, make it as complicated as you want, all the way up to micro-simulation models. It's really up to you, but I think this is one of the things that is worth thinking seriously about because there's a real danger if you get it wrong. You know, one fantastically wrong forecast can have a severe impact on your reputation as a workforce center, and that's hard to recover from because really, as a workforce center, your reputation is based on the quality of your data. And if you can't, if other people can't rely on the quality of your data, then they're not going to come see you very much. They're going to be suspect of the things that you turn out. And I think that's the kiss of death for a workforce center. You have to be seen as being reliable in the information that you put out and objective. Those are the two critical factors, I think. Besides, you know, an awful lot can be accomplished by focusing just on the supply side and doing profiles of your workforce and your educational pipeline so that you understand what the trends are in your pipeline. You know, is it growing? Is it shrinking? Those sorts of issues are actually really important to understanding the dynamics that are happening in your state. And so I don't think it's absolutely essential that a workforce center needs to do demand studies, but it's becoming more expected, I think. Hopefully there are some things in the works nationally, people who are creating some models that can be used at the state level to do some supply or demand forecasting, and I think that will help. But doing it on your own is difficult. So, and I want to sort of summarize this by saying it's important to keep in mind what the value is of your workforce center. What does it bring to your state? These are the reasons for having a workforce center, no matter how you're funded. This is the value that a workforce center brings to the state. And maybe really the most important point here is the last one, that a workforce center is a forum for understanding how the healthcare system is changing and how those changes intersect with your existing education systems and with your regulatory bodies. There are dramatic changes happening right now in healthcare, changes in who has access and how that access is being structured, big changes in reimbursement that impact the way that health systems are thinking about staffing and delivery teams. And there's a real redistribution happening in terms of responsibilities in the delivery system itself, from the very highest level to the lowest level. New types of personnel are being developed and are being used in new ways. So in the past, health workforce analysis used to be fairly simple. It was kind of a counting system. How many did you have? Where did you have them? Where weren't they? How many were you turning out? How many were going to retire? Were we producing enough new ones to take their place? But the truth is that these days it's become much more complex, and we really need to be thinking about health workforce in new ways and developing some new approaches to measuring workforce and understanding who's doing what out there and how it's changing. So I think that's it. You know, it's hard to compact 20 years of experience into 30 minutes, but I think I've given you a pretty good overview. I would be happy to take any questions.
Thank you, Linda. That was a very interesting talk. At this time, we'll start the Q&A session. Once more, you may ask questions using the chat panel on your screen. And please make sure you direct your questions to all panelists to ensure that they have an opportunity to be answered. Okay, Linda, I believe we have the first question already ready to go. Can you describe some of the limitations of secondary data sources? Why can't we just use BLS data for our workforce studies? Minnesota found projections for dental hygienists were way off for their state compared to licensure data.
Well, it's an excellent question, Katie. Well, a couple of reasons. I think, first of all, you really need to understand how those secondary data sources are developed. What was the research behind them? Who was included in that research? Who was excluded? And you know, the devil really is in the details here. In the case of BLS data, for instance, BLS actually measures jobs. They measure employment, I should say. Jobs might not be the right word. They're measuring full-time employment, not persons. And so, you know, there's never, when you're looking at the number of full-time employment versus the number of people to fill that full-time employment, those numbers are never going to match because some people work part-time and some people are out of the workforce temporarily, and so there are reasons why numbers might not match. Legitimate reasons, but also, you know, you need to know that you're comparing apples to apples, and that can sometimes be difficult. So really getting behind the numbers, never just take a number at face value. Make sure that you understand how that number was developed and what it's based on and what types of bias might be in that data.
Thanks, Linda. Great answer. For a new health workforce center still trying to collect or capture data, What can we do to begin to address workforce issues in our state?
Well, I think the first thing is really to talk with your partners and with the stakeholders in your state. You know, sometimes just some simple conversations over the phone can help, but I think more importantly is to think about how you want to structure those stakeholder relationships. Do you have an advisory council? Are you using your advisory council not just to sort of rubber stamp what you're doing, but to ask some of the big questions? You know, who knows about pending legislation? What are your professional associations worried about? That doesn't mean you have to accept all of the things they're concerned about, but I think it's important to understand what the context is in the state and the need for data to fill that. If that's not very helpful, then I have to tell you, I think the thing that really worked best for us in South Carolina, the first year that we really got rolling, we produced a data book that took all the information that we had available, and we had a lot for the professions, but we also include demographic information and vital statistics and information on health disparities and health status and some facility data. We put all of that together into a book that broke the data down by county. So we have 40 counties in the state, and for every county, they had their own numbers, and then we did a number of regional aggregations, again, using the same data, but just presented it in slightly different ways. We did some maps that showed where our professionals were practicing. That was a big hit and continues to be the way that people identify us. You know, when I meet someone new and I introduce myself and they say, oh, you're the people that do that book. That makes me smile because that's great. They're using it, and it can be used to address a wide variety of issues. It really is just a reference book. But when you put it all together in one place, package provider information with health status and disparities information, it goes a long way. We were actually inspired to do that by the County Health Rankings project that has come out of the University of Wisconsin. And I think for communities that are interested in improving health in their areas, one of the things they need is information about, well, what resources are available to them, what kind of providers actually practice in this county. So I think that's actually an easy way to get started and to make a splash.
Thanks, Linda. Okay, next question. Can you tell us more about your GME studies? What were the policy implications for this work?
Oh, well, actually, they turned out to be great. We're still sort of in the process. The task force met over a period of 6 months and developed a final report that made 15 different recommendations. The bottom line, though, is that for the first time ever in South Carolina, there has been some very concentrated attention paid to the mismatch between who we're educating in our graduate medical education system, which is about 60% specialists and about 40% primary care. The mismatch between that and what it is that we need in the state, which is more primary care. And so the recommendations covered a wide range of things, from requiring that teaching hospitals who have GME programs be required to do some data tracking, and that there will be an evaluation of how our GME system is changing over time and whether that 60-40 split is getting closer to 50-50, which is what we would like it to be. There's also, unusually, a big discussion about the role of NPs and PAs in meeting the state's needs. And one of the recommendations is that some of the funding that has been going to GME programs be redirected to nurse practitioner and PA programs to develop more of those folks who will practice in primary care and in underserved areas. There's also attention being paid to some of the existing programs in the state that do career development in general, but especially those that focus on minority students, getting more minorities into the health professions. And a lot of attention is being paid to the idea of rural training tracks. Currently in South Carolina, we only have one, and it's very small. And so as a way of addressing the problem of getting people into underserved rural areas in our state, we want to develop more rural training tracks. And so that will require some research, first of all, to figure out where those kinds of training tracks might be most successful and where they would meet the biggest needs. Let's see. And the other thing was that one of the recommendations is to create an ongoing advisory group to routinely look at GME program policies and funding and attempt to make graduate medical education in our state, not just for physicians, but also for PAs and NPs, more in line with what the needs of the state are. And that's really focused around, recruiting into rural areas, which has been difficult and is getting more difficult as years go by, and making sure that our underserved areas and our underserved populations are better served. And also, there's a data element there. There's a recommendation that our office be supported to help with some of the data tracking that will be necessary and some of the data evaluation systems that will be needed.
Thanks, Linda. What are some of the funding considerations / challenges that you've had at both North Carolina and South Carolina that other states might benefit from hearing?
Funding challenges. Well, funding's always a challenge. Everybody finds this challenging. When I was in North Carolina, we were completely state funded. We had a very generous budget. It was about $500,000 annually, and we had a staff of 5. It was very secure, and that allowed us actually to really concentrate on what we were doing. We spent all of our time doing research and not writing grants, and of course, that has a big impact on your productivity. So we were very productive. But it's kind of live by the sword, die by the sword. During a year when there were serious budget shortfalls in the state, we were cut completely. Now, there's also some background to that in terms of some policy squabbles that we got involved in. And remember, when I was in North Carolina, one of our arms was an advocacy arm. So we did both research and advocacy. And I think that while our research was very well appreciated and widely used, the advocacy arm got us into a little bit of trouble. It got a couple of people angry with us, and I think that contributed to the fact that we lost our funding. So that was one of the reasons that I put this into my lessons learned. In South Carolina, as I said earlier, we started up with grant funding, and that has been wonderful. Again, it allowed us to get off to a fast start because we had some very solid funding to begin with. But right now, we're learning that the best way for us to proceed is really to begin to piece things together. I have to say that having good, solid funding when you first get started might be a bit of it might actually hold you back a little bit, because if you're hungry and you're looking for funds, you're looking for projects, it really forces you out the door to meet people and, you know, sort of get out into the weeds to find out who's doing projects that you might be able to help with. So, you know, I think having secure funding, while it's lovely, also I think keeps you from pushing as hard as you might in developing partners that, for your long-term survival, are very valuable.
Thanks, Linda. Next question. Why is AHEC such a great partner for this work?
Oh, well, you know, when I took this job, one of the reasons that I took it was because it was seated inside of an AHEC. AHECs naturally have a workforce development orientation. And so, you know, it just makes sense for AHECs to be involved somehow with workforce centers, whether it's to, you know, try and get one off the ground like we've done here, or if it's just to act as a major partner. But the AHECs have all sorts of good information through their career development programs and through what they might be doing with residents and residency slots that I think is just a natural. Maybe most important is that the interest is already there. AHECs are very focused on the development of the primary care workforce, and they have a lot of interest in everything around that workforce development question. And so I think that they are a natural partner just because they're inclined to think in similar ways. They also have their ear to the ground. Most AHECs have statewide networks developed, and they hear what's going on. And it could be that in our state we have 4 different regions. Each of those regions has a board of directors of some sort, and I have found it really helpful to go out and make presentations to those boards around, you know, workforce issues in their area. The feedback I get is tremendous and really gives me a lot of insight into the next question that I should be addressing as a workforce center.
Next question. How do you make your voice heard, get a seat at the relevant tables, and establish yourself as a data resource without advocating?
Well, I think there's a difference between having an advocacy role to promote a profession, advocating in that sense, versus advocating for good data to inform policy decisions. And I would say that that really is the role of a workforce center, is to advocate for the idea that policy should be based on data, not on guesswork and not on politics. You know, states spend millions, billions of dollars in terms of educating health professionals in service delivery that depends on a good health workforce. There's a lot of money spent, and those resources really should be spent wisely. And without having good information, sometimes it's really just a guess as to whether or not they're meeting their goals, or they'll have the people that they need to start new programs or whatever. I think that you do have to advocate for yourself. And it's not for yourself as an individual, but for your center, which is dedicated to the idea of creating neutral, unbiased information that can be used to inform policy discussions. And honestly, generally people love data as long as you don't hit them over the head with it. You know, don't ever take people tables, only take them charts and maps, pictures. Don't ask them to pour through data because you'll lose them, their eyes will glaze over. But it's amazing to me how having 1 or 2 pieces of salient information dropped into a discussion about, you know, do we really need to develop a new program around this, or do we have what we need to develop a new program? it makes a world of difference.
Thanks, Linda.
And I would also say that people are generally very positively responsive to that.
Okay, another question for you. Do you track unlicensed health professionals, and how do you do that, if you do?
That's a great question. Right at the moment, we don't have a good tracking system. Actually, you know, the best way that I have found so far is through the IPEDS data, which every higher degree, well, every school actually that gets any sort of federal funds in this country is required to report the number of students they have enrolled and the number of students who complete either their certificate programs or their degree programs every year. And so that's a good way to understand what the educational pipeline is in your state for some unlicensed folks. At the very least, you will understand how many are being produced and how that differs around the state. What you won't get in that data source are the shadow or sort of on-the-job training programs that happen, and those are very real, but I don't think that for most unlicensed groups that is not how they're getting educated. Most of them are going through some sort of formal curriculum, whether it's you know, through a college or university or a community college. And AHECs can certainly help with showing you the numbers on the types of people that they're doing programs for that might relate to some of the unlicensed personnel that are being developed. Community health workers would be one example. You know, in some states, there are already formalized education programs for community health workers, and there are expectations for regulation around those groups. But in other states, a lot of community health workers are being trained through AHEC programs or through hospital association programs, that sort of thing. It can be tricky, especially with a brand new emerging group of unlicensed professionals or occupations.
Thanks, Linda. Last question for you. Your data book is beautiful. Do you have any other best practices or tips for communicating and disseminating your data and reports?
Well, in addition to our data book, we also use fact sheets, which are usually 1 to 2 page sort of you know, data summary. We usually have 1 or 2 charts to address a very specific question, and I think those are great because they're short, they're very to the point, and you know, people just don't read like they used to. So I think keeping things very short and sweet is good, and also, you know, making them fairly pretty. Again, I try to stay away from tables and rely very heavily on maps and charts for communicating data. A good chart really just is a wonderful thing. We also have a huge mailing list that we send out to, and every time I meet someone new or someone contacts us looking for information, I add them to our mailing list, and we send things out on a regular basis. So I think that matters. Disseminating data, you know, you can put great stuff out there, but if no one's talking about that issue at the moment, it's going to fall on deaf ears. So I think one of the tricks, and it truly is a trick, is to try and have, you know, a small amount of information available at the point when people are talking about an issue. So in our state, a while back, there was a question as to whether or not we needed a new medical school. And it turns out that that medical school has opened, but during that discussion phase, you know, that I happened to have some information about retirements. I knew how old our physicians were, and I knew how that differed by specialty and geography. And so I was able to provide to the group that was having these discussions you know, a couple of charts that showed, well, this is how many we can expect to lose over the next 20 years due to retirement, and this is the number that are coming in every year, and it doesn't look like we're going to produce enough new physicians to cover the ones that are leaving. So that was really one piece of information, easily obtained, but it made a world of difference to that discussion, and it had a big impact. So I think when you're talking about communicating and disseminating, it's great to, you know, be able to just kind of throw things out there, but if you just put it out into the ether, there's no guarantee that it's going to fall where it needs to fall. You need to try and target your information as much as you can within reason.
Thank you, Linda. That was a great presentation. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.